good morning, everyone. As Dr. Regan was saying, my name is Karen Dennehy, and I'm the Irish Clinical Educator Track Fellow here with the RCI working in UHW this year. And I've just been tasked with kind of putting simulation in context for all of us who are trainees in present day. In order to do that, we just go back a little bit to So we'll go back to a landmark report by the Institute of Medicine that instigated massive change in medical education over the last 2 decades. So the name of this report was "To Err is Human," and that's a quote from a famous poet called Alexander Pope. And it just means as humans, we all make mistakes. And what that report showed was that there was a 3% risk of medical errors of hospitalized patients in the US. So at that point, it was felt like the apprentice style of education, which is see one, do one, teach one, was no longer applicable to a modern day healthcare system and to appropriate safety and well-being of our inpatients. So I suppose in the States that started a kind of thought process of what are the alternatives, and to make clinical education engaging for trainees. I suppose you need practice, you need the trainees to have buy-in. So they thought about maybe artificial representation of real world processes and achieving educational goals through experiential learning. Experiential learning is the process of using knowledge and understanding that you already have and linking that to new kind of experiences and knowledge. So building on that foundation as you go. So simulation is ideally placed for this because you mimic real life processes, but the learner has no fear of causing any harm to any patients. It can be a repetitive process. So medical simulation allows us to gain clinical skills through deliberate practice rather than that older apprenticeship style of learning. But in order to get kind of learners to be engaged and buy-in, you need to have a degree of fidelity, so kind of likeness to reality. So you need that in order for kind of your learners to perform, to practice, and to gain clinical skills. So the uses of simulation. So the general applications. So communication skills, and we'd all have been through that doing our MRCPI exams, where there's communication skills kind of simulated scenario. Integrating competencies in clinical situations, team training, in ACLS training, use simulation. It can be used in kind of complex, rare, or dangerous situations. So, the treatment of malignant hypothermia or obstetric emergencies that trainees might not see very often. And then using technical skills training. So using a task trainer to kind of a more basic level, for IV cannulation or for lumbar puncture training. But then looking at where we are, which is postgraduate medical education, how can we apply it? So I suppose it's more of a higher level. So using critical thinking in emergency situations, using analytical skills, specialized procedures, in kind of growing our leadership skill set, especially as we all work in kind of multidisciplinary teams, utilizing decision making, growing our interpersonal skills, and kind of showing professionalism. So when we use sim as a training tool, we have control over the sequence of tasks offered. So, often when you're on call, you're thrown in the deep end tasks that you might not feel always comfortable with. With using sim, you can slowly build up skills, starting at a lower level and building up, which is a more comfortable place if you're a learner. Obviously, there's support and guidance when sim is ran well. No one feels too exposed, and it's a learning opportunity more than anything else. You can help prevent unsafe and dangerous situations by kind of empowering your learner and growing your kind of knowledge base before you actually have to put those skills into practical use. You can create tasks that really occur in the real world, like different emergencies, if you wanted to build up the learner's knowledge base. And you can do tasks that, might be limited by materials or resources, like lumbar puncture training. You mightn't have a lot of patients who'd be willing to let someone try on them or practice on them, whereas you can use a task trainer instead. And then it's really useful, again, for ourselves in interprofessional education. The WICOP sim that's used here is predominantly used, with the multidisciplinary team, community-based, and it's really helpful for breaking down professional silos that can build up. Not so much in geriatric medicine, I think, because we work really well with other people, but maybe in other specialties. So there are challenges, and there's always going to be challenges for change and acceptance utility. So just to touch on some of those. So the technology, so as I said, you kind of have to have a degree of fidelity. So the scenario needs to feel real, and your location needs to kind of feel real as well. So you can use a mannequin, but they obviously won't be able to reproduce clinical signs, facial expressions, or maybe react to the learner. Then you can use real people. However, if you're doing a sim on sepsis, they won't look like a septic patient. And sometimes higher technologies are quite expensive than lower technologies. This can be overcome in different ways because you can do simulation in situ, just using a clinical area that you might have, rather than a purpose-built simulation lab if cost is an issue. The research. So simulation-based medical education definitely empowers, I suppose, clinicians and trainees. It definitely helps to improve clinical skills. But I think we will need to see kind of growing evidence, and there is growing evidence that it will improve clinical outcomes for patients, because that's where money and funding will be coming from. The costs that I mentioned, so using in situ simulation can reduce costs, but that comes with drawbacks because you're trying to use a clinical space that is very valuable in every HC hospital. And then faculty development. So, qualifying trainers, I suppose they have to want to build up that skill set, and that takes time. And sometimes people feel more comfortable if they're using any skill regularly. So if you've been trained in sim, but you don't have the opportunity to utilize your skills, sometimes people can de-skill and maybe become less confident in it. And I suppose for us, what does simulation look like in the Irish landscape? So some colleges have been employing simulation for a long time. So the College of Anesthesiologists have been utilising simulation in their training since 2010. RCSI with surgical trainees have been using simulation and have invested heavily a number of years ago in a very highly sophisticated simulation building. So that's slightly covered, but obstetric gynecology have a very firmly embedded simulation training in their BST and HST. Last month, Colin Henry, the HC Chief Clinical Officer, came out saying how important simulation is as a tool to develop clinical competence and gain experience and skills for all of us. Prof. Dara Byrne, he'll be speaking later, has been appointed the lead of the National Simulation Office. This is a new office that will help support the rollout of simulation in all clinical sites over Ireland. And then for ourselves in internal medicine, a report was published, Optimise, in August about the future of kind of the BST and internal medicine training for Irish trainees. And that has advised that all simulation sites should have access to simulation. Sorry, all training sites should have access to simulation, and there should be a lead for simulation in internal medicine in all of those hospitals. So that's something that's going to affect us more and more as we progress through our career. Is a simulation strategy document that was published about a year ago, and that is available to everyone, and it has step-by-step guide on how to develop simulation in your facility. Development of a faculty, it has really good resources there for writing the scenario and also kind of utilizing the resources that are there. And there's HSC and DTB funding for development of simulation sites in hospitals. And again, Professor Dara Byrne is a source of support, I suppose, for everyone that's trying to roll out simulation in whatever clinical site they may be in. So the future, which is everyone here, I hope everyone wants to work in Ireland and work as a consultant in the near future. So I think simulation will become increasingly embedded in medical education. I think it's strongly embedded at an undergraduate level, and it's going to be increasingly embedded at a postgraduate level. And we're all going to be leaders in that, leading it out, I think, in the future. As healthcare moves more to community settings, I think simulation will follow, and we see that here in Waterford with the WICOP simulation lab that's gerontological based and focused on the community and engaging loads of different key stakeholders. I suppose studies of educational effectiveness will drive the practice in simulation, and that will guide how it's driven in the future. And I think there's endless opportunities with AI, ChatGPT kind of writing simulation-based scenarios, virtual reality, which is already used in kind of endoscopic or laparoscopic training. I think that can be rolled out more so, but that will obviously need further funding. So I think simulation, in summary, is going to be part of all of our futures here, and hopefully get a lot out of it today and enjoy it. So thank you very much.